Welcome to the Deep Dive, your shortcut to getting comprehensively informed.
Glad to be here.
Our mission today is pretty laser-focused. We're taking a deep, mechanistic journey into the core pharmacology of antipsychotic therapy.
Right. And this isn't just about memorizing drug names.
No, absolutely not. It's about understanding the why, the molecular principles behind how we treat one of the most complex conditions in medicine.
And we're really pitching this for you, the highly informed learner. Think of yourself as a second-year med student who's about to hit the wards and needs this clinical grasp.
Exactly. You need to understand why the first generation, failed in some ways.
And how the second generation tried to fix it, but in doing so created a whole new set of problems. It's really a story of pharmacological innovation that was, well, it was driven by some really devastating side effects.
Okay, so let's unpack this. I think the best way in is with a clinical anchor. We have to frame the symptoms before we can even talk about fixing them.
Makes sense.
Let's use the case of Luke. He's a 22-year-old male, recently admitted for acute psychosis. And if you look at Luke's presentation, you can immediately see the three classic symptom clusters that define schizophrenia.
Let's start with the loudest ones, the ones that usually get a patient admitted. The positive symptoms.
Right.
These are experiences that are added on to reality, things that shouldn't be there. For Luke, he's hearing his deceased mother's voice.
So, auditory hallucinations.
Exactly. And he has this firm, unshakable belief that other people can read his mind, that they can control his thoughts.
Those are the classic delusions of control. It's all about excessive disorganized brain activity.
Perfect way to put it. Then you have to pivot completely to the other side of the coin, the negative symptoms.
These are the qualities that are functionally taken away from his personality.
Yes. So Luke is. He's emotionless.
Yeah.
He speaks in this low, flat monotone.
That's affective flattening.
And crucially, he stopped bathing, he stopped shaving. That severe drop in goal-directed behavior is what we call avolition.
You also see the motor part of it sometimes, right?
Yeah.
Catatonia. He might just sit for hours without moving at all.
And these deficits, they're often much, much harder to treat than the positive ones.
And what about the third cluster, the one that's often overlooked?
The cognitive symptoms. And you could argue these are the most functionally disabling of all.
How so?
Well, Luke can't focus. He can't maintain attention. His working memory is just shot. A patient might get their hallucinations under control, but if they can't think clearly, they can't go back to work. They can't reintegrate into their life.
So this complexity, this disease of both excess and deficit, that brings us right to the core theory.
The dopamine hypothesis.
Everything in antipsychotic therapy really rests on this idea.
And what's so remarkable is that this entire theory didn't come from some brain imaging breakthrough initially. It came purely from observing how existing drugs worked.
Okay, so what was observation number one?
Observation one, you take drugs that dramatically increase dopamine activity. We're talking amphetamines, cocaine.
Yeah.
They can actually induce, or at least severely aggravate, an acute psychosis. That is, for all intents and purposes, clinically indistinguishable from schizophrenia.
So if more dopamine causes psychosis, then less dopamine should treat it.
That's the logic, and that leads directly to observation two. Every single clinically effective first-generation antipsychotic drug blocks the D2 dopamine receptor.
Every one of them.
And here is the absolute bedrock of the whole field. The clinical potency of these drugs, how well they treat psychosis, correlates almost perfectly with how tightly they bind to the D2 receptor.
And it has to be D2, specifically, not D1, not D3 or D4.
It's all about D2. This is what makes it the primary target for treating those positive symptoms.
Okay, but hold on. That brings up a huge question. If it's a dopamine disease, why are there both symptoms of excess, the positive ones, and symptoms of deficiency, the negative ones?
That is the $64,000 question.
Because if you just block dopamine everywhere, aren't you going to make the deficiency part of the disease even worse?
You are, and that's the key. Schizophrenia isn't a global dopamine problem. It's a disease of imbalance across very specific brain pathways.
Okay.
So you have two pathways that are critical here. Pathway one is the hyperactive mesolimbic tract. This runs from the VTA to the nucleus accumbens.
And this is where there's too much dopamine.
Way too much. And that excess is what's driving Luke's hallucinations and delusions, his positive symptoms.
Got it. So what's pathway two?
Pathway two is the problem of deficiency. The hypoactive mesocortical tract running from the VTA to the prefrontal cortex.
And in this pathway, there's a deficit of dopamine.
A major deficit. And that is what we strongly associate with the negative and cognitive symptoms, the avolition, the flat affect, the poor memory.
So this functional dichotomy is everything.
It's crucial because if your drug is just a blunt, global D2 blocker,
It's going to help in the mesolimbic pathway.
right, it'll quiet down the positive symptoms, but at the same time, it's going to slam the brakes on the already hypoactive mesocortical pathway, pushing it into an even deeper deficit.
And that perfectly explains the limitations of the first-generation drugs,
Exactly.
which is a great transition to them. The first generation, or typical antipsychotics, the neuroleptics. We're talking about drugs like haloperidol, chlorpromazine.
Massive leap forward at the time. But as you said, they are the definition of a double-edged sword because of that blunt mechanism.
Their core mechanism is just potent D2 receptor antagonism. That's it.
That's the whole story. They work incredibly well for positive symptoms because they just flood that mesolimbic pathway and shut down the excess dopamine. They're a chemical sledgehammer.
But because that action is totally indiscriminate, they block D2 wherever they find it, they do nothing for the negative symptoms.
Well, and in fact, they can actively make them worse by deepening that dopamine deficit in the mesocortical tract.
Okay, and this is where it gets really interesting and clinically vital. That indiscriminate D2 blockade doesn't just hit those two pathways. It hits all four major dopamine pathways.
And that leads directly to the severe side effects that define the typicals.
Right, so let's talk about the other two tracks. First up, the nigrostriatal tract.
This is the pathway that governs voluntary motor movement, and it relies on this delicate balance.
Balance between what?
Between inhibitory dopamine and excitatory acetylcholine. Dopamine is the brake, acetylcholine is the gas.
So when you introduce a potent D2 antagonist, you're essentially cutting the brake line.
You've cut the brake line, the cholinergic activity surges unopposed, and that causes a whole host of movement disorders.
Which we group together as extrapyramidal syndrome, or EPS.
Right. And you see these acute Parkinson-like symptoms, muscle rigidity, tremor, slowed movement bradykinesia.
And also that horrible inner restlessness, akathisia.
A truly awful feeling for the patient, a compulsive urge to constantly be in motion.
And that's the acute problem. What about the long-term cost?
That would be tardive dyskinesia, or TD. And this is the one we really worry about because it can be permanent.
And it shows up later, right?
Yeah.
Months or years into therapy.
Often, yes. And it involves these involuntary, repetitive movements, grimacing, lip smacking, that classic tongue protrusion.
And what's the mechanism? It's kind of ironic, isn't it?
It's deeply ironic. It's caused by the chronic blockade, making the dopamine receptors super sensitive. They actually upregulate in response to being blocked for so long, which is why the movements can persist even if you stop the drug.
Wow. Okay, and there's one more we have to cover here. The life-threatening emergency.
Neuroleptic malignant syndrome, or NMS. It's rare, but the mortality rate is still around 21%. It is a true medical emergency.
And it has a classic tetrad of symptoms, right?
Yes. The first is severe lead pipe muscle rigidity. The second is hyperthermia, with fever spiking over 40 degrees Celsius.
Then autonomic instability. So wild swings in blood pressure and heart rate.
And finally, altered mental status. It's caused by a sudden catastrophic drop in central dopamine activity, and it requires immediate aggressive care.
Okay, so that's the motor system. What's the final pathway that gets hit?
The tuberoinfundibular pathway. And this is all about one hormone, prolactin.
Right. Dopamine's role here is to act as a brake on prolactin release.
Exactly. It's a continuous tonic inhibitor on the anterior pituitary. So when a first-gen D2 antagonist comes in and removes that brake,
You get a flood of prolactin, severe hyperprolactinemia.
and the clinical signs of that are really significant for patients. You see galactorrhea, which is spontaneous milk flow,
Amenorrhea women, gynecomastia in men.
and widespread sexual dysfunction and infertility. It's this high neurological and endocrine price tag that just, it screamed for a better solution.
Which led directly to the second generation, the atypicals.
The unacceptable side effect profile of the typicals was the direct motivation. We're talking about drugs like clozapine, olanzapine, risperidone.
And these represent a huge shift in strategy. It's not about blunt force anymore.
No, it's about modulation, precision.
And the key mechanical innovation here is this dual action.
Yeah.
It's weaker D2 blockade.
Combined with potent serotonin, 5-HT2A, antagonism. And that serotonin piece is the absolute game changer.
Okay, so explain that connection. How does blocking serotonin help a dopamine problem?
It's brilliant, really. The 5-HT2A receptor normally acts as an inhibitor on dopamine release. It's another brake.
So by blocking that 5-HT2A receptor,
You disinhibit dopamine release. You're essentially cutting the brake line for the brake line. This enhances dopamine release, but specifically in the areas where it's deficient.
like the mesocortical tract.
Precisely. And also, crucially, in the nigrostriatal tract.
So now you get the best of both worlds. The weak D2 block is still enough to help manage the positive symptoms in the mesolimbic tract.
But the 5-HT2A modulation effectively gives a little dopamine boost to the hypoactive mesocortical tract.
Which gives you better, though maybe not perfect, efficacy for the negative symptoms.
Right, and even more importantly, that 5-HT2A antagonism in the nigrostriatal pathway protects motor function.
Because you're getting a little more local dopamine release to counteract the D2 blockade.
Exactly. So the atypicals have a significantly lower risk of EPS and TD. They also generally don't cause high prolactin.
But there's a big exception there we need to mention.
A very important one. Risperidone is a major outlier. It raises prolactin almost as much as the first-generation agents do. You have to remember that one.
Okay, this sounds almost too good to be true. But in pharmacology, we know there is always a trade-off.
Always.
So if the atypicals solve the neurological problems, what's the new price you pay?
The trade-off is fundamental. You trade that neurological risk for a very high risk of metabolic syndrome.
And this is the primary clinical headache with the second generation.
It absolutely is. You're managing patients with significant, often rapid weight gain. You're monitoring for an increased risk of type 2 diabetes and severe dyslipidemia.
Meaning high cholesterol and triglycerides.
Yes. And mechanistically, this isn't tied to dopamine or 5-HT2A. It's linked to their blockade of completely different receptors.
Primarily the histamine H1 and serotonin 5-HT2C receptors.
Right, which are central regulators of appetite and metabolism. And you have to know that there's a spectrum of risk. Clozapine and olanzapine carry the highest metabolic risk.
While some of the newer agents like ziprasidone or aripiprazole tend to have a lower metabolic burden.
Which brings us to the latest innovation, because it's not just about simple antagonism anymore. Aripiprazole is the classic example of partial agonism.
Okay, let's unpack that. If D2 antagonism is a hard off switch.
A partial agonist is like a dimmer switch.
Okay, explain that.
Aripiprazole acts as a partial agonist at the D2 receptor. So in an area where dopamine levels are way too high, like the mesolimbic tract, it competes with dopamine and brings the overall signal down. It acts like an antagonist there.
But in an area where dopamine is too low.
Like the mesocortical tract, it provides a low level of stimulation. It acts as an agonist, so it helps normalize the whole system rather than just shutting it down. It's a system stabilizer.
That is clever. But we can't finish this deep dive without talking about the big one. The gold standard outlier, clozapine.
Right. It's reserved for treatment-resistant schizophrenia for a reason. It is hands down the most efficacious agent we have.
It often works when nothing else has, and it's the only antipsychotic approved to reduce the risk of suicide.
And its unique efficacy probably comes from the fact that it's a bit of a messy drug. It's a weak D2 blocker, but it's very potent at other receptors like D4 and 5-HT2A.
But that exceptional efficacy comes with exceptional risk.
Yes, which is why its use is so restricted and requires specialized monitoring.
Let's start with the most famous risk, the reason for the mandatory blood work.
A granulocytosis. This is a severe, potentially fatal drop in white blood cells, specifically neutrophils. It basically compromises the immune system.
And it happens in about 1 to 2% of patients.
Which is why you need that constant, regular blood monitoring. If you see the drop, you stop the drug immediately.
And beyond the blood risk.
You also have to watch for a high risk of dose-related seizures. We see that in 2 to 5% of patients, and also myocarditis, which is inflammation of the heart muscle. Managing a patient on clozapine is a major clinical undertaking.
Okay, so before we wrap this up, let's broaden the scope a little. It's really important for you to see antipsychotics as a versatile toolkit, used for a lot more than just psychosis.
Absolutely. They are central to managing bipolar disorder, both for acute manic episodes and as long-term maintenance therapy.
Olanzapine, quetiapine, risperidone are all staples there.
They're also used as an add-on therapy for treatment-resistant depression. You'll often see aripiprazole or quetiapine used with a standard antidepressant.
And some of the older agents still have their niche uses.
They do. Haloperidol is still used for Tourette's syndrome to control tics. And a drug like chlorpromazine is a powerful antiemetic and anti-nausea drug because of its D2 blockade in the part of the brain that triggers vomiting.
Right. So if we step back and try to summarize the two absolute key principles you need to take into your practice.
Hmm.
What are they?
Okay, principle one. D2 blockade, whether it's full antagonism or partial agonism, is the core mechanism for treating the positive symptoms of psychosis. That's the foundation.
And principle two, which is maybe the most crucial for clinical decision-making. Selecting an agent is always a fundamental trade-off.
Always.
Are you going to manage the neurological and endocrine side effects of the typicals? The EPS, TD, NMS, and the high prolactin.
Or are you going to manage the high metabolic consequences of the atypicals, the severe weight gain, the diabetes, the dyslipidemia? There's no free lunch.
So your role as a future clinician really comes down to vigilance.
Vigilance above all else. All these drugs have serious risks. You need to be doing movement screens and checking prolactin for the typicals.
And rigorously monitoring weight, glucose, and lipids for the atypicals. And of course, that specialized blood work for clozapine.
Exactly.
So let's end with a final provocative thought for you to take away. We've established that the entire field of antipsychotics was built on the D2 receptor.
Right.
Yet the single most effective drug we have, clozapine, is famous for being a weak D2 blocker, while it acts powerfully on many other receptors, like 5-HT2A and D4.
The clozapine conundrum.
What does the persistence of that conundrum suggest about the limits of our current dopamine-centric hypothesis? It should really encourage you to think about how much of the real key to success lies not in just hammering the D2 receptor, but in that subtle modulatory balance provided by the serotonin system and maybe other targets we're still discovering.
Something powerful to think about as you start your training.